we will hear from our next presenter who really needs no introduction, Dr. Christine Hahn. The IMA has stood up an old committee, the IMA Public Health Committee, and we're really excited about the robustness of the membership that's developed, and we're so pleased that Dr. Hahn has joined this committee. So thank you for that. Dr. Hahn attended medical school at Michigan State University, completing a residency in internal medicine at Mayo Clinic's Graduate School of Medicine, and a fellowship in infectious disease at Duke. She then joined the CDC's Epidemic Intelligence Service, and today she is the Idaho State epidemiologist and medical director in Idaho's Division of Public Health. Please help me welcome Dr. Hahn.
Thank you. Thank you so much, Dr. Williams. I really am so excited about the Public Health Subcommittee being stood back up. Susie knows we've been hoping to do that for years, and obviously no better time than during a pandemic. And I'm really excited by the group and the energy and the work that we've already accomplished. So thank you again for that. I'm presuming you can hear me, and can you see my screen? Okay, perfect. Okay, and I know that you have more business to do, so I'll try to even finish before the hour, and hopefully we'll have some time for questions. I was asked last spring or early summer to talk about kind of a COVID update, and I thought, wow, it'll be kind of old news by then. And I remember I just kind of making this presentation, I went back to some news stories from last March, the kind of the feeling being like, oh, thank heavens that's over, and I really was thinking, I think for the IMA presentation will be sort of this wrap up, lessons learned summary of the situation. Obviously that's not where we are. And I just, I only came in towards the end of it's been a very busy day here, and I was not able to listen. I was hoping to hear more of the presentations today, and I haven't been able to, but obviously you guys are well aware. And I think what I like about these images to me is they summarize, I think, where so many of us are at emotionally right now. One is the incredible amount of work and the hard work that is going on. And then on the left hand, this to me symbolizes the feeling, at least, and I will say that a lot of what I was hearing, and I was assigned into a breakout group, which was great. It's a lot like what we feel in public health, and that is that to a certain extent we've been battling for a year and a half, and there's a sense of failure, a sense of when's this ever going to end, and what could we be doing differently? And we've been saying, we feel like we're saying the same things over and over, but it's not working. So anyway, so I just want to acknowledge that. And at the same time, now we are starting to see from experts, public health experts, the sense, and I think many of us are starting to sense this, that it'll never be over, really, that this virus may, more and more people are saying, may become endemic. And the idea that we are going to get this vaccine roll it out, and this virus would sort of fade away. And I think about other fears we've had that have done that. SARS-1, if you guys remember SARS back in 2003, we were all very worried about it. Asia, then to Canada, a few cases in the US, and then gone. MERS, the Middle East respiratory syndrome, another scare, never took off in the United States, has never expanded worldwide. Even the pandemics we've experienced in our careers have been managed. They weren't as bad as we had feared, and we were able to kind of get back to our normal lives very quickly. But this coronavirus is not doing that, and we're, I think, starting to come to grips with that. In thinking about it, I didn't know this really until despite my infectious disease background, I really didn't understand the pandemic in 1918 very well. I think many of us, when I first learned about it, I thought, why did I never learn about this in like American history class or anything? It was at the end of World War II and World War I, and people were just ready to move on. It was a lot of trauma, I think, in the world, and this just wasn't focused on. But one thing to be aware of is that virus is still with us. And that H1N1 that caused the 1918 pandemic continues to circulate in the population. It caused outbreaks in various years, as you can see here from this article. And most recently, in 1947, it caused a total vaccine failure in a lot of cases. And then in 1957, it was replaced by another flu virus, H3N2. Popped back up in 1977, and now it co-circulates. As we all know, we have two influenza A types that circulate. We have two A subtypes and two B subtypes that have circulated really ever since then. So but the H1N1s that we deal with today are descendants of the 1918 flu. So is that possibly something we are looking at with this virus? Interestingly, and I just learned this a few days ago, so we all know we had a very mild flu season last year. This I think is fascinating. Only 0.2% of respiratory specimens in the US during flu season were positive for influenza. Nobody predicted that. Even the influenza experts that I talked to at CDC, we were all worried we'd have a bad flu season last year. Social distancing and masking probably helped a lot to suppress it. But even worldwide, they were seeing less influenza. So the question is, if this coronavirus managed to somehow knock this down, whereas we normally will see periods of time where we'll have about 30% of respiratory samples positive. But interestingly, because of that very quiet year last year, there are actually suggestions now that one of the B subtypes, the Yamagata, might be extinct. It might have gotten knocked out completely. We'll see. These viruses, as you saw from H1, do tend to pop back up. And I just have this slide as an example of a really stark showing how mild the flu season was. In previous flu seasons, there are usually close to 200 pediatric deaths reported around the country. And in the last season, there was only one. So just a remarkable decrease. So where are we at now? Those of us that talk about waves, we call this the fourth wave. And the good news has been in the last few weeks that case counts nationally have been dropping, mostly due to decreasing activity in the Southeast, Florida, Georgia, Alabama, Missouri, even parts of the state. Worldwide mirrors to a large extent what's happening in the United States. A lot of this data, of course, we have countries, some of the less developed countries provide less data. But this little peak here, I think many of you might guess what this is. That does not show up in the US data. That is India having their large Delta wave earlier in the summer. So right now, we are starting to see a flattening or a decreasing, which is good. So moving into Idaho a little bit, we are struggling right now with our data. I just had several meetings yesterday and today, to talk about our data. You may be aware that some of our local health departments are struggling right now to get the data into our system. We don't believe this decline is real. We think that it is more likely that our cases are flat, but some of our health districts, especially some of the larger ones, are so overwhelmed with cases right now that we've had to put this disclaimer. We put this on our website, I think just yesterday, that please don't assume that this is a real decline. We're feverishly working to correct this. This is unacceptable. We know that schools, hospitals, individual citizens, our court system uses this data to decide how severe things are. One of the biggest areas that we have seen this drop and just inability to keep up with the numbers has been Ada County. And we've been working, we are actually sending some of our state epidemiology team to the district health department here to help get this caught up. So hopefully in the next few days, we'll be in a better place. But we can't rely on our case data, and we never have completely. We all know that people don't always get tested. People aren't always symptomatic. That's not perfect data under the best of circumstances. So I'm going to get back to some of the stuff happening in Idaho, but I wanted to make sure I had time to cover a few key recent events and make sure I talked about them. The third doses that we're all aware of that came out for immunocompromised people. More recently, the booster dose recommendation that came out for seniors and for some other populations. More reports of sick kids due to Delta variant, and then of course the monoclonal antibody treatment center. So let me just cover some of those. So just in a nutshell, people with pretty severe immune compromise. So we're talking people with on active treatment for cancer, transplant recipients, people on either steroids or other types of immunomodulating or immune suppressing agents are now basically, I would just consider them all to be recommended now if they're getting the mRNA vaccine, so the Pfizer or the Moderna, that they get 3 doses. And so the first 2 doses, that schedule hasn't changed depending on which vaccine they're getting, but 28 days after that second dose, they should get a 3rd dose. So that recommendation has been out now since late August. However, the booster addition to that has been quite confusing to people, and for good reason, which many of you are aware of to a certain extent. So it kind of started here, much to our surprise, and I am a liaison member to the CDC's Advisory Committee on Immunization Practices, or ACIP, that make these recommendations. And I was taken by surprise, as were other members of that committee, that the White House announced August 18th that we're going to start doing booster shots for everybody, pretty much. This is a quote taken from this press briefing by our Surgeon General. And it basically says, we're announcing our plan by being prepared to offer booster shots to fully vaccinated adults 18 years and older. And then he goes on to say, well, this is pending all of this federal action. But what people heard, of course, what the media took up and what we all heard was that pretty much everybody is going to be recommended to get a booster starting September 20th. So the media picked up on this right away, that this was a White House decision, not necessarily a CDC decision at this point, or a recommendation. What Pfizer actually asked for, Pfizer actually said, okay, we've got our 2-dose schedule. That's all fully licensed now. Pfizer has the licensed vaccine, of course. What they said is, we would like to have licensure of a 3rd dose for anyone 16 and above who got our product, and have them get a 3rd dose 6 months after their primary series. So that was the ask. And so what happens after the Pfizer, so we had the news from the White House, then we had the news that Pfizer had submitted a booster request, and then each of these 4 events generated more news. This is FDA's Advisory Committee. They met September 17th, and they said, nope, we do not think everybody needs we don't think we have enough data. I should put it that way. We don't think we have enough data to authorize a booster for everybody. You guys haven't done enough work, Pfizer, for that. But we do say, not as a licensure, but as an emergency use, we do recommend to the FDA that this get authorized for seniors and high-risk people. So then it got turned over to the FDA. The FDA accepted that recommendation, but they added one important tweak, which was institutional setting. So this now opens it up for potentially having a recommendation for people in jail or prisons, or who reside in other institutional settings other than, let's say, a long-term care facility. Goes to CDC's Advisory Committee, and they turn this into a recommendation now. And this isn't just who it's authorized for, but who should get it. And they came up with people 65 and older, residents in long-term care, people 50 to 64 with underlying medical conditions. That's who they say should receive the vaccine. And the medical conditions we'll talk about in the next slide. However, they also said the following may receive a booster shot, so kind of a softer recommendation. And this would be people 18 to 49 with underlying medical conditions. And you know who is missing from this is healthcare workers. So the Advisory Committee did not feel there was enough data to support a recommendation for health or occupational workers. And this is where you saw the news headlines later that CDC overrides their committee. They did adopt everything the committee recommended, but they added people 18 to 64 who are at increased risk for occupational or institutional settings. So kind of going back to the language allowed under the booster authorization. So sorry to walk you through that, but it was very confusing at the time. And every time you see a news story, it just seemed like felt a little whiplashy. So I put this slide together to kind of keep it all straight. If you want to know the details, again, which medical conditions are we talking about? Which occupations are we talking about? That's all on the CDC's website. They have information about booster shots, including what they mean in a little more detail. So kind of to wrap up the booster shot discussion real quickly. So as a reminder, and this gets brought up a lot during the ACIP meetings, vaccination of unvaccinated people is our highest priority. People who are seeking boosters, absolutely, it is recommended that they consider getting a booster, but they are not driving this epidemic, as I know many of you are well aware. It is the unvaccinated people that we need to keep focusing on: education, opportunity, provision. I think sometimes we feel like the people that aren't unvaccinated at this point, we've done all we can. They know it's out there. Why keep trying? And yet I just heard today from a colleague, someone he talks to regularly, and she says, "Oh yeah, darn it, I just need to go get that shot." You know, and I think those of us that work in healthcare are probably like, how can you still be doing that, putting a note on your refrigerator and not quite getting to it every day? But people are complicated animals, and I think we need to take some encouragement in the fact that people are still, I'll show you Idaho data in a little bit, but there are people that, believe it or not, have put it off until now, but they're still going to go get the shot. So Moderna and J&J, if you're like me and you got Moderna, there is no recommendation yet for booster shots, but just today, the FDA did announce the dates. I think October 14th and 15th, they're going to be meeting to talk about boosters for Moderna and J&J. So within a couple weeks, we may have go through the same process again, but with Moderna and J&J, hopefully FDA and CDC have smoothed out some of the bumps and will be a little cleaner, but stay tuned. That's coming shortly. We expect plenty of vaccine this time. The manufacturing has been ramped up, and I think it'll look quite different. In the US, most vaccination now is through pharmacies. That's actually not true in Idaho. We have a much lower percent of our vaccinations that are being registered are coming in through pharmacies, closer to 40%. But what's nice is we know that there's a lot more capacity out there, and people can just swing by and get a booster, and they're only needing one, not 2 doses. So it's a lot less complex. Also, only about 2/3 of people who got their primary series in a nationwide survey said they were going to get a booster. So we're seeing the same in Idaho. I'm sure some of you are experiencing this. I actually had volunteered to do help with the booster shot clinic tomorrow, and they've told me they don't need me. They've had to scale it way back because they have so little interest. And I think that's what we're seeing around the nation. There just isn't the demand that we thought there would be for probably many, many complicated reasons. But we're starting to message more about booster shots and trying to, I know you all are too. I hope that people eventually go get those. So far, no reports of shortages of vaccines or people having problems accessing the boosters. Here's our vaccine data. It's updated every day on our dashboard internally. And you can see here, this is the last day on this was just yesterday. There's sometimes a lag of a day or two for people to get the data into the system. So we never rely on those last couple days where it looks like a big tail off. There's probably doses still being entered in. But you can see here with our lowest week was right on 4th of July. And really ever since then, we did get a little bump, I think partly news of the Delta variant, partly Pfizer getting licensed. Some people said, I'm waiting until it's fully licensed. Some people did go get vaccinated after that. I hope there was some back to school activity there. We did see an increase in 16 to 17-year-olds and 12 to 15-year-olds getting vaccinated for all sorts of complicated reasons. And the diligent efforts of you guys and healthcare workers talking to family, friends, and continuing to get the message out. So we have seen a rise, and we're doing about 20,000, per week, which is not too bad. However, I just want to show you this. When we look at if we look at everybody who's eligible, so this is just among people 12 and up. This is everybody together. You can see here that it's going to be a long time before we even get close to, 80% we initially set as our target. That's back when we were still thinking 80% might give us herd immunity. It'll be a long time before we get close to that at this rate. We have seen a little bit of rise lately, but we're nowhere near where we would like to be. So children, we know that with children, more and more news right now about spread, a lot of discussions about schools. You may know that the Idaho Education News, I believe, is where you can go now and see a site, and you can see every school district, which ones are requiring masks, which ones are, not, et cetera, because it's been quite a hodgepodge with schools even school boards even reversing course one way or the other quite regularly. So it's a hard thing to keep up with. So a lot of discussion right now about children, and a lot of parents waiting to hear about vaccines for children. I don't think I have a slide on this because I just learned this today as well. The FDA has set, I think it's October 26th. They will be discussing doses for 5 to 11-year-old in late October. Oh, yes, the 26th. And they said that they're still waiting for final data from Pfizer. This is for Pfizer, but they are anticipating having that data and anticipating being ready to have a conversation October 26th. So hopefully by sometime in November, we will actually have a vaccine for 5 to 11-year-olds. This is from the CDC website. So you can see here cases in children this is the black dot bar or line, I should say. You can see cases in kids have been increasing steadily really since August. And so far, we have not seen an increase in multi-system inflammatory syndrome of children. But like we saw last winter, there is a lag, an expected lag, because children don't present with the syndrome usually until 2 to 3 weeks after infection, and often are asymptomatic, don't even realize it, but we are expecting to see increases. Just has not happened yet. If we're lucky, maybe Delta variant is less likely to cause that. We don't know that for sure, but no increase yet. Idaho has done relatively well. This is a report put out weekly by American Academy of Pediatrics and the Children's Hospital Association. And you can see here, this is just population level cases of COVID per 100,000. And you can see here that Idaho has fared relatively well so far, below the national average as far as our case counts among kids. However, like throughout the rest of the nation, we are seeing quite a dramatic increase in the last few weeks among children. You can see the blue here is your 13 to 17-year-olds. Your 5 to 12-year-olds is that green line, and you can see those older children, as it were, are really skyrocketing in rates. Partly, I'm sure, due to back to school and more children, closer to each other, sports and other activities. Among the 0 to 4-year-olds, though, we also have seen an increase, just not nearly as dramatic. I already mentioned now that I forgot I had this slide in here. This was the announcement from Tuesday that that FDA had received some data from Pfizer. And now that's been updated that, again, we're hoping to have their meeting October 26th. So the last thing I wanted to talk about, depending on our time, is the monoclonal antibody treatment centers. The governor announced late August that he was putting some state money into trying to set up additional treatment centers in northern Idaho, eastern Idaho, and in the Treasure Valley. You may be aware that in several states, especially in the southeast, they've been heavily promoting monoclonal antibodies. And I have very mixed feelings about them. I'm sure many of you do too as well. We worry that people using them as an alternative to getting vaccinated, meaning that they say, I don't need to get vaccinated. If I get sick, I'll just go get that antibody treatment that I hear is really good. And what I find puzzling about that, which we hear frequently, I find puzzling about that is another term for this would be passive immunization. I mean, you are immunizing that person with antibodies. And it is also experimental. It is under emergency use, as were all 3 vaccines, and as 2 remain. So I don't understand the acceptance of this compared to vaccine, but we have been hearing that, and we have to message very carefully. We want to know people to be aware that this treatment is available, and we want to make sure it's available, but we don't want that to be, I think I've used the analogy, like we want the vaccine to be the seatbelt and then the monoclonal antibodies, the airbag, if you somehow still need it. But we worry that about people turning to this as a first defense. So real quickly, there are approximately 30 providers, and I say approximately because sometimes we'll get an order from a provider, but then they won't order more, or they say we're not doing that anymore. It's a constantly changing field. Until a few weeks ago, providers could order monoclonal antibodies directly from the federal government. They did purchase, like they purchased vaccine. The federal government has purchased these products, so there's no cost to the provider. However, 2 weeks ago, because of increasing demand, it got thrown back at us that we are now, the federal government allocates to the states, and then we allocate out to providers. So, and we found out Tuesday, 2 weeks ago, that as of yesterday, as of Monday, it was this new process. So we've been scrambling, but very proud of our ability that there was no interruption in services in Idaho. So the providers that ordered it have all continued to receive their product. And in addition, through the governor's initiative, we have Heritage Health, which is an FQHC in Coeur d'Alene, has partnered with the Northwest Specialty Hospital to establish a new site. They have been using the Coeur d'Alene, or I should say the Kootenai County Fairgrounds, but they also have other sites. In addition, Idaho Falls Mountain View Hospital has expanded their hours using this funding, and they are adding a Blackfoot and possibly a site in Pocatello to offer more monoclonal antibody. Lastly, we've had conversations this week with 2 agencies in the Treasure Valley. One is an FQHC, which we really strongly support, so that access isn't just limited to people with the most savvy know-how and resources and connects and all that. It is we want to make sure we have access for as broad a population as possible. So we're not quite ready to announce that yet. We're waiting for kind of final proposals, but hopefully next week we will have that up and going. As you can see here, just kind of going back to, this is looking at, I hope many of you are familiar with public health districts. I should have put a little map in. But you can see here that demand throughout the state and use of this has increased over the last month or so, last 6 weeks or so. And we are seeing increasing use. District 4 is, roughly, Ada County and Elmore and some of the other counties in this area gets the most, but is certainly, we are trying to keep an eye on keeping it proportional to population now that we are involved with the distribution. And we also have a cap, of course, so we need to keep an eye on fairness. We just completed our orders for this week, and I'm happy to say that we were able to give everybody the product they needed. In fact, we've seen a little bit of a bump, I think, because we were not getting as much as per our population and per our case rates as some of the states in the Southeast. So we're actually seeing a little bit of a bump in our allocation, and we're hoping that that continues. It is a good product. I've seen, you may have seen this week in New England Journal of Medicine, I didn't have time to add this into my slide deck, but a paper just came out looking at real world effectiveness of one of the 3 products, RegenCove. And I had to calculate, they always talk about percent decrease in hospitalization of maybe 70 to 80% decreased hospitalization, which sounds great. But I always try to calculate the number needed to treat, which says more to me. Some other studies have shown as few as 8 to 10. Treating 8 to 10 people will keep 1 person out of the hospital, which is really great return on investment. This New England Journal of Medicine article, by my back of the envelope calculation, seemed like it was closer to 30 in their study. But I think it, regardless, it also decreases people's symptoms by 4 days and their viral load. So it is probably preventing spread in our community as well. But we have to remind those people they still need a vaccine. So I'm going to stop here. I had a couple other topics I could cover, but I know you guys have a lot more work to do. I just can never give a COVID talk without showing I think the dog memes are my only bright spot. One of my bright spots in this pandemic has been some of them. This guy in the right-hand corner, I've used him before but I found a few others, which I just find them adorable and they make me smile. So I'll pause here in case there are any questions for me. I think the other slides I had we will only get to if people have questions pertaining to those areas.
Thank you very much, Dr. Hahn. I'll turn the Q&A session over to Susie.
Thanks, Dr. Williams. Dr. Hahn, we love dogs here at the IMA, so we very much appreciate your memes and all of your great information. So there are some questions that have already popped up in the chat. If there are others, send them our way and we'll answer as many as we can. So the first question came in from Nicholas Henry, by the way, IMA Foundation Award winner. Dr. Henry, and he says, as far as I'm aware, there's a lack of clinical data, especially RCT data, behind a booster/third dose of the mRNA vaccines. Is there pre-published data that helped this recommendation get pushed through, or is this all still based off antibody titer studies?
Yeah, that's a great question, and that is one reason why this is why you saw this flip-flopping craziness. I think the data is. I think if the White House hadn't made that announcement, these meetings might have occurred a little bit later. There was tremendous pressure on FDA and CDC, I am sure, to get a recommendation out right around the time that the White House had announced it. And I'm sure there are people that felt like, you hear both sides of the spectrum. You hear people saying we don't have that data yet. We really don't have the clinical data to say we need a booster. And you have others saying, look at what's happening in Israel. And I'll say, for those of you that are really interested in delving into this, if you go to the FDA's committee site, which is VRBPAC, a terrible acronym, but their Vaccines and Related Biologicals Products Advisory Committee, they have a great presentation from Israel showing, and that's what was shown to the committees, was in Israel, they were having cases go up, 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 and they started giving boosters to seniors. They started with 60 and above. And they show that in other age groups, the case rates kept going up, but in 60 and below, it just nosedived. And they showed that people who were having breakthrough infection that had 2 doses, the further away from their vaccine series, the more likely they were to have breakthrough. So Israel had some very solid clinical data. On the other hand, that's Israel. There's always that, what they call ecological fallacy, right? You take something from another country and you don't know. There are a lot, for example, they only use Pfizer there. They don't use Moderna or J&J. And also, so it's a little bit of a different population. They have obviously different age groups. They have different ways of detecting cases, a different surveillance system. So in short, great question. You're right. The clinical data in the United States is lacking, and that is one reason why it was so controversial.
Okay, thank you. Next question, does Dr. Hahn think that we've missed the window for preventing future SARS-CoV-2 variants developing that will require a new vaccine?
Yes, I think that is the growing consensus in the community, in the medical, the vaccinology community, is that we did miss the opportunity to prevent variants from continuing to evolve, and we're going to keep seeing them evolve. That doesn't mean, as you guys all know, when they evolve, they're mutating randomly. It doesn't mean it's going to get worse. It doesn't mean that it's necessarily going to escape the vaccine, but that is the concern. Just by chance, when those do arrive, that is the big concern. And what they're hoping is kind of like the 1918 flu, which, remember, there wasn't a flu vaccine back then, so it wasn't about escaping a vaccine, but just through natural evolution, it has actually gotten less severe. It is still certainly very contagious. So yeah, I think we have probably missed the window, is the thinking.
Okay. The next question is there any emerging data as to whether COVID-19 infections in pregnancy are teratogenic?
Yeah, thank you for that question. I have not seen that data. I have to admit, COVID in pregnancy, and also we are getting more and more questions about the vaccine during pregnancy, which, as you are probably all well aware, is recommended, is something that I think St. Luke's this week was going to start talking about and emphasizing. And I think those of you that work in the hospitals know, I think the hospitals are seeing pregnant women coming in with COVID. And I have not caught up on that literature. I have not seen it. I try to keep an eye on everything, and I haven't seen anything about it. But that's so I think what that means is so far there must be at least only emerging literature on that, but not a lot.
Okay, and the next question is there a difference in effectiveness of REGEN-COV given IV infusion versus subcutaneous?
Another great question. You guys are very astute. So if you look at the emergency use authorization for REGEN-COV, it says that IV is strongly preferred. And I, for quite a while, was setting up these sites around the state, kept saying, you've got to offer IV because the EUA says that that is strongly preferred. It must be better. And then I couldn't find any clinical data to support that. I did talk to a physician who is the medical director for this effort for Health and Human Services. And he said they are trying to get that language changed, that there is growing evidence that sub-Q was approved only based on levels of the antibody in blood. It was felt like it wasn't as strong clinical data, but they say they're getting the clinical data, and we can presume for now that sub-Q is effective, and hopefully that language will get changed because I kept pushing for the IV, but it looks like the sub-Q is probably going to show to be as effective, but stay tuned for that. The data is not firm yet.
Great. Okay. Next is another shout out for the dog. And then after that is a question about what was the definition of severe disease in the Israeli studies?
Yeah, that's a great question. I know that for many studies I've looked at, severe disease is defined. There's like very strict criteria. So for example, hospitalization. And yet some studies I've seen will also include an ED visit as a solid marker of severe disease. I don't recall what Israel used. I believe they used hospitalizations, but I would have to go back and double check that. Or of course, excuse me, death. I mean, people die at home or not in a hospital setting, that would also qualify.
All right. Thank you for all of your hard work during the pandemic. Why was the Israeli data discounted since we were talking about the Pfizer booster?
Yeah, I would say it wasn't discounted. I think there was some discomfort in the United States with not having, we're used to having data from studies in our country, and I think it just felt a little strange because again, Israel is different in a lot of ways. Their population, for example, they don't have the same racial and ethnic diversity we do here. You can't always completely extrapolate from one population to another. I think there was just discomfort, and I think it was a way to push back at Pfizer a little bit, like we need to see your data from the United States, where we'd prefer to see that. I think that just caused some angst.
Thank you for that. And then folks can see in the chat just from Nampa to Pocatello talking about some unfortunate situations with OB patients. Very sad. Dr. Hubeli's question, I haven't seen much regarding COVID, encephalitis, seizures. Can you comment on the frequency on this?
Yeah, Susanna, that is a great question. I actually don't know that off the top of my head, but I agree. I'll just make a general comment. And I see studies coming through every day, like you all. I have services that send me medical articles, and I feel like sometimes when the lay public talks about COVID, they think you live or you die, and if you live, you're fine. And I think that what we forget is all the terrible things that happen to people that survive and can left with, of course, not just long COVID, but just severe disabilities. And of course, having had encephalitis or seizures can lead to severe morbidities. And I wish we had a better way of talking about that. I think one of the challenges has been, as you know, just today I saw a study out of Wuhan, China. They're still publishing a lot. We have many different medical centers publishing data, Europe, as well as other countries around the world. And it's very hard to feel like you have a single number that you can remember of, oh, this is the risk of seizures, let's say, in a hospitalized COVID patient. So I'm sorry, Suzanne, I don't have an exact number for you on that, but it's certainly a problem.
Okay, there's an observation from Dr. Henry about the studies that weren't very large in Israel. And then Dr. Dillian has a question. This last year, we saw higher rates of RSV. Do you anticipate higher rates of flu this year?
Yeah, thank you. First of all, just make a quick comment to Dr. Henry's comment. The other thing amazing to me about Israel data is they started their booster program July 30th. So it's not like 6 months of follow up, or I mean, it was so recent, and this was presented to the committees in early September. So it's really I think that's another, thank you for pointing out another reason for the discomfort. It feels really fresh, really late, really recent data, and not very well vetted and not published. All of it, some of it was, but not all published in medical literature. So to Dr. Dillian's question, so you are probably aware we also have seen RSV this summer already, like in Idaho and other states. And this is very unusual to see RSV this time of year. We don't usually start seeing it till November, December, kind of more like it has a respiratory seasonal pattern, kind of like flu. So yes, we are worried. And again, we said this last year and we were completely wrong. But this year, knowing that a lot of people are no longer masking, obviously kids are back in school. They're not doing online school as much. There's a lot more mingling of the population. We're very worried about flu. Very worried that it could make a roaring comeback. And of course, everybody's immunity level is a little bit low because, if you didn't get vaccinated, which hopefully you all did, but if you didn't, you've had now 2 years that you probably haven't been exposed to influenza. So we're very, very concerned about a severe flu season. And there's a nice publication in MMWR looking at not only RSV, flu, but some of the other respiratory viruses and having thoughts about possible surges of these other respiratory viruses as well.
Dr. Burgess coming in with the $1 million question. Dr. Hahn, do you have any thoughts on how to get the public to understand and believe the facts?
If I did, I would be very famous, very rich, all of it. No, we, of course, one thing we all mull over, and I'm sure you guys do too, is I think we're used to living in a world where we disagree about what to do about a problem. So there's poverty or gun violence, and we can have different ideas about, well, we need to do this. No, we need to take, make guns completely out, whatever. People have different, but I feel like here we're talking about, are there guns or are there not guns in this country? Like the facts we don't agree on. And that is very unsettling. And I think none of us know what to do about that because we're so used to, okay, here are the facts. Now, how do we solve it? And we can all fight and disagree about how to solve the problem. But if you don't agree on the problem, it's very challenging. I can tell you that health and welfare has really decided to full bore use misinformation as their current thing. They're not just encouraging people to go get vaccinated, but they're really trying to do more and more communication about misinformation. But one thing I just heard this week was, for example, we put out a tweet about something kind of correcting a myth or explaining something. And she said they got over 800 comments on that. And what a lot of them do is in the comments, they'll put links to other misinformation. And so they're worried that are we becoming a platform for the people that disagree with us to actually get their word out? So it's very, very challenging. And I do think we just need to keep telling our truth. And, the fact that we're still getting people vaccinated, it's not what we want to see, but we just have to keep persevering, I think.
Yep, thank you for that. And I think IMA is weighing into that arena as well and trying to do everything we can. Our social media sites retweet a lot of information from Department of Health and Welfare and put out other things too. So happy to partner with you on that. I would just call out in the chat, Dr. Dunay pointed out that there's an ECHO Idaho session next Tuesday that's actually going to feature a case about COVID encephalitis. So take note of that.
Yeah, I'll be listening.
Good. Okay. Dr. Martin has a question. In your opinion, how hard should we push for masking in schools? In North Idaho, as myself and fellow pediatricians tried to move the bar in the right direction, a mob took over the school board and the meeting was canceled. I think we all saw that in the news. So 2 board members have resigned. I mean, what a tough situation. Sorry, Dr. Martin and Dr. Hahn, if you have any thoughts on that.
Yeah, that's a great question. Again, I think, and I really admire, I just want to call out also Dr. Pate, who has been tireless in his work with the schools and in his just work at all, being out there and being a strong voice for science and public health and medical recommendations. And I think he's just really been brave too in wading into the fray in many ways. I think we need to continue to be a strong voice that masking is the way to keep kids, what we keep saying is we all want the same thing, which is we want our kids in school. I have 2 kids at Boise High, and they wear their masks every day. And I am so grateful that they're going to school. They were home. One of my kiddo did online school last year. Oh my gosh. At any rate, I think we need to keep saying it. I don't think any of us should be endangering our lives. I was able by Zoom to talk to the Coeur d'Alene School Board about a month ago, and there were people at that meeting, and I was on Zoom, thank heavens, but that were that had to be taken out of the meeting. I don't think anybody should be risking their personal life for this, but I think when asked, and we need to be a strong voice for masking. I really think it's keeping kids in school.
Great, thank you for that. If there are no other questions for Dr. Hahn, I'm going to ask you to stay with us, Dr. Hahn, and bring Dr. Williams back in because he has a presentation to make.